My name is Anthony Borelli, and I manage the product and the marketing team for Fujifilm in the US. First off, I'd just like to say congratulations to the Orlando Health team. You all continue to raise the bar as it relates to just clinical education, but overall physician education, so kudos. As I mentioned, I'm with Fujifilm, and historically we've been known as a double balloon company. What you may not realize is over the past few years, we've brought and introduced 20 plus new technologies for GI in the endoscopy space, and that includes the acquisition of Hitachi from an ultrasound standpoint. So we're very proud of the innovation that we brought to the endoscopy space and appreciative of this opportunity. Today we have two pioneers in endoscopy, but also pioneers as it relates to EUS, talking on a few different topics. Professor Itoe will kick us off. He'll be talking specifically about a new linear endoscope, echo endoscope from Fujifilm, and how that's a game changer. And then Professor Dupre will close us out, and he'll talk a little bit more broader level around some of the new cutting edge technologies from Fujifilm as well. So with that, I'd like you all to welcome Professor Itoe to the stage.
So, good afternoon, ladies and gentlemen. It's my great pleasure here and having me here. First of all, I'd like to thank Professor Love and Thomas for giving this wonderful chance. And also, I'd like to say thank you very much, Fujifilm. So my talk is why the new Fujifilm EG240 UT endoscope is a game changer. So mostly you don't know this new scope. Many years ago, Fujifilm created this, and now so we are frequently use this endoscope. I have some disclosure here. As you know, nowadays there are several linear EUS scopes. As you can see, Pentax, Olympus, and Fujifilm, in particular Fujifilm EG580 UT is a common the linear echo endoscope in now. And nowadays we have a very nice the echo endoscope. The Fujifilm EG240 UT. There are a lot of function like you can see, and so in briefly, I'd like to show the advantage of this scope. First is shorter bending radius. This is very important. So sometimes it's very difficult to get teeth because of the difficult anatomy or others, and so this short bending radius so enables easy access to the ideal target. And the second is a wide angle puncture directions, providing wider FNA accessibility. Small tip, small endoscope tip, and so short bend allows a very wide range puncture side. And the third, guide wire locking system. So no more expertise of assistant. Expertise of the guide wire holding. So without any support, guide wire automatically locking. So very nice during the exchange of the devices. And first, this is the most important. We can see easily the endoscopic imaging when deploying the devices. In particular, during this live demonstration, you can see hot axios deployment very easy to see, and one of safety and reliable deployment possible. So in addition to the endoscope, now we can use the ALERT 850. 850 has also a lot of function. Of these functions, detective flow imaging allows DFI. It allows observation of the ultra low velocity blood flow. So you can see comparing to the current EG 580 UT, the Arieta 850 plus EG 740 UT shows very nicely the imaging of deeper portion at the depths of 2 to 5 cm, very clear. Moreover, the imaging has EOS like Doppler or others. As I mentioned, DFI shows very nicely low velocity blood flow, like contrast enhanced EOS. Let's see, in this case, IPMN, and so cystic region can see, and just color Doppler, no more color signal. However, you can see the DFY. You can see a very precise small vessel. Yeah, of course. See, contrast enhanced EOS by Sonoview or Sonozoid can display very nice precisely. But as you can see, DFI is one of good modality without any contrast enhanced EOS. So for it's kind of PDAC, you can see here the PDAC and color Doppler, no signal as usual. But DFI can show, of course, not only the normal vessel, but also small or tiny low velocity flow. So elastography, like very hard, and the contrast enhanced EOS showed. So basically hypovascular tumor, but so you can see a precise small vessel. Almost similar to DFI in my impression. That's why so DFI is the next game changer of this field for diagnostic EOS. By the way, so you can see the development of interventional EOS nowadays. A lot of interventional EOS during, as you can see during this live demonstration. Let's see the US guided acute necrotic correction drainage by with EG240 new echo endoscope. The echo endoscope image is also relatively nice. You can see a very perpendicular, nicely imaging, and open the hot axials, and slightly back towards the gastric wall. And then you can see a very nicely endoscopic imaging. Of course, we frequently use the interworking channel releasing technique, but even though sometimes scary during the deployment of the proximal flange, but so easily can see without any elevator change. Of course, you can use the elevator more and more clearly get the endoscopic imaging. Or from this is the G and Sham video. Open and the French, and so you can easily see this proximal flange. And the USGJ later, so I will show the USGJ. So West techniques, just water pushing and open the distal branch in the jejunum. And the gastric side can see easily, can see. I guess my impression is better than Olympus. To the Olympus, I'm sorry, but it's a real world. And this is the final movie. It's guided gastrojejunal, or in the afternoon session, I will show you this procedure. You can see a very distended jejunal. Then, so the puncture, very nicely perpendicular imaging, and deploy the proximal branch, distal branch, and pull back. And finally, you can see a very nice position under endoscopic imaging. So, ladies and gentlemen, my conclusion, easy to put a new linear endoscope maybe or would be ideal US scope for safe and reliable interventional US. In particular, it plus Arietta 850 provides a fantastic DFI mode showing precise low velocity blood clot. And finally, it may be a game changer. It will be a game changer for diagnostic and therapeutic US. Thank you very much.
So we're going to have time for discussion at the end of both lectures. Professor Itoy has got a challenging case back at the hospital. So we're going to release Takao to go to the hospital, and now we'll welcome Pierre Dupré to the podium. Thank you.
Well, yes, my impression about the new EUS scope is exactly the same than Professor Itoy. And the first time I used it, I was really impressed. And for sure, we are going to work with this new endoscope. But in fact, Fuji asked me to give a broader view on all the innovations that are coming and that are given to us by Fujifilm. Of course, I have a disclosure to show you. In Belgium, Fujinon at the time was known for its double balloon development with Professor Yamamoto. And this really revolutionized the investigation of the small intestine. And progress is going on, and they are going now to launch, Fuji is going to launch a new double balloon endoscope, 740T, with some new features such as better imaging and water jet function, which is very important. I'm not performing double balloon enteroscopy myself, but my colleague Tom Morales is very experienced, and he told me that these new functions were very important to improve diagnosis and treatment with investigation of the small intestine. So when I had to prepare this lecture, I had to go over the double balloon and the endoscope and go to all the new innovations from Fuji. And I was quite impressed because I was not aware of all the developments. And you see all the features and the technologies that can be associated with the platform developed by Fuji. So I'm not going to cover all of these technologies. Some of them may be going to the base. The base is, of course, the new light sources with the use of LEDs, LEDs, to improve illumination and to be able to do some pre-processing of this illumination. The first one used for detection, which is called LCI, linked color imaging in Fuji. And you see that this way to treat the wavelengths and the image improve the detection of abnormalities, such as in this view of the esophagus. So that's first detection. Next step is characterization, and they developed blue light imaging, which is similar to the NBI we use with Olympus. And that's very helpful, of course, to characterize, for example, the lesions, the adenomas and the polyps in the colon, and you've seen pictures and videos about this system. So all this is then brought together with the new Eluxio platform, where you can use a system called Color Assist, which is nice to train new endoscopists to have a full insertion of the colonoscope in the colon. Combined with LCI for detection and the AI system developed by Fuji, which is called CAD-EYE. Characterization with BLI and CAD-EYE. Measurement, which I will show you a short video on the scale eye to measure the lesions before resection. And then you can use specific scopes, such as the GI scope for the colon, to improve treatment capabilities. So let's go to AI. I was really impressed by Jacques Berman's lecture yesterday, and I think he did a beautiful lecture and telling that the first step, in fact, with artificial intelligence was to allow us to be sure that we had a complete examination of Barrett's or stomach or the colon. So CAD-AI was not really developed for that. CAD-AI was developed to detect and characterize and improve the detection rate during colonoscopy using AI Fuji technology, which is called Rayleigh. And this was developed not only for endoscopy, but also for radiology. And of course, the radiologists are more and more dependent on the AI developments. That's a Fuji video, short video, 40 seconds, showing you the detection and showing you how it's, in fact, easy to manipulate these scopes and to shift from the normal image to the CAD-AI vision using LCI for detection and BLI for characterization. And you see that's not interfering with the clinical images, such as seen with other systems. You don't need to look at multiple screens, and you see that it helps you to characterize those colonic lesions with a small, just by using the knobs on your scope. Yeah, I had some pictures to be sure if the video were not running. You see that's detection with the LCI mode, and this is characterization with the BLI mode. So what about the data? I'm not going to cover what Jacques Berland told us yesterday. Most of the studies show a higher adenoma per colonoscopy or ADR detection rate compared to high-definition conventional colonoscopy. Although, as he told us yesterday, when you go for more experienced endoscopists or colonoscopists, there is not much difference in the ADR. But in a recent Swedish study covering several hundreds of patients, although they could not see any difference in ADR, they could see an improved detection of SSL lesions, the serrated lesions. So this may prove important to prevent colorectal cancer. So I think we need more data about this. And the European guidelines delivered a position statement about this, delineating the anticipated value of AI endoscopy, stipulating that AI should be used to elevate the adenoma detection rate of less experienced endoscopists. But that means that we should not only train less experienced endoscopists, but also experienced endoscopists to evaluate and to use the system and to be able to train young ones. Now going to the scale eye, which I think it's a nice innovation, because we know that we are either under evaluation or over evaluation the size of our lesion. I'm not doing colonoscopy myself, but I do a lot of duodenal resections, and for sure they are always under evaluated, if not completely malpositioned in the duodenum, and sometimes confounding ampullomas from sporadic adenomas. So I think evaluation of the size is important. I have a short video showing this, and this is based on the, well, of course the DM is to take them out. It's based on a laser pointer that you have to place on the left of the lesion, and then it can give you either circles or a line that will be very precise and give you the size of the lesion. I think this is quite a very interesting innovation, not only for training young people, but also for more experienced. Not only innovation in technology, but also in scopes. And you see a development for colonoscopy using GI scope, which is a scope equipped with a balloon. And this balloon may also increase the adenoma detection rate and help you in intubation, in the detection, because it will flatten the folds, in characterization, because it can stabilize your scope when you want to characterize a lesion that's positioned in a difficult place, and also improve treatment by stabilizing the treatment. So that's an evolution in the scopes. But Fuji is not only using a gastroscope and colonoscope, they also develop tools, and you know the flush knife. We have seen several cases using the flush knife. There is also the clutch cutter that can be used to facilitate excision of tumors. And they also develop track motion rotatable jaws to be able to stabilize and to use a kind of traction device to help resection. And this device can be put then on a new dual channel endoscope. When you perform third space endoscopy, having in your room a dual channel scope is always of interest, especially when you have complications, because then you can increase the possibility to suture and close large defects. And you see this is a dual channel scope with two channels of 3.7 and 3.2 millimeter. And then on this scope you can adapt the track motion device to be able to track the lesion and to cut and dissect. But of course I'm a US lover, so I have to say some more words on the combination of the Arietta and the new scope. I will not speak about the scope because Takao Itoi mentioned all the new features of this scope, but you see the evolution in the last years with the different systems and the different scopes, and you see on these pictures that really there is a really improved performance in imaging. And of course, this system, this platform allows us to use contrast harmonic imaging, which is used in Europe a lot, not with Sonazoid, but with Sonoview. And there are many studies showing the impact of contrast on pancreatic lesions and on submucosal tumors. But first time, 2 years ago, when I saw the DFI, I was really amazed by the capacity. And I thought that contrast would disappear. There is still a debate among experts because it's not giving the same information. Indeed, detective flow imaging is based on pixel movements. It's not based on Doppler. So we may miss some uptake enhancement capacities that are given by contrast. But still, just pushing on a button and having these beautiful pictures is for me a revolution. And how can we understand this? But you see these on these graphs, you see that flow imaging based on Doppler is very much conditioned on movements of your scope. And this is much less a problem when you use DFI. And you see that the resolution of DFI is of a very high level. And this has been proven in recent studies, mainly from Japan, but there are many centers in Europe doing randomized trials comparing contrast enhanced and DFI. And you see this was the first study published by the group of Masaki Tano in submucosal tumor, showing that it was more sensitive than E-flow and had a higher accuracy for pancreatic lesions. And a recent paper just published in Digestive Endoscopy this year on submucosal tumors, showing also that DFI was almost equivalent to contrast-enhanced imaging. And of course, the platform allows you to use elasto, strain elasto, shear wave measurements, although the results are quite disappointing for pancreatic diseases, but there may be a lot of development in endohepatology using this technology. So just to summarize, I think Fujifilm provides us with innovative, I would say, toys and tools, because when you love endoscopy, if you have a beautiful tool, it becomes a toy and you enjoy doing it. And we were discussing with Roche about liking endoscopy and making it difficult not to perform it anymore. And they, of course, give us the possibility to use AI with the system CAD-I to measure lesions, as I showed you with Scale-I. So now we need to make the best of it. We have to improve training and introduce these tools to train our young trainees. I hope I was able to show you that I have a huge portfolio, including conventional and non or more advanced endoscopes, such as the colonoscope GI, the new double balloon, the US scope, and the double channel scope. And I also developed and market now multiple endoscopy devices for resection and for third space endoscopy. For EUS, I think it's really a game changer, for sure. And of course, we are waiting the next steps. Fuji is a very big company. They have a lot of money. So I think they will continue to develop new tools and maybe AI in other fields. Maybe AI, as Jack Berman told us yesterday, to improve quality control of endoscopy. And then we will need, of course, to validate all those new tools in. Thomas is very keen on that, on randomized and proper studies. Thank you for your attention.
I'll maybe have you stay there for just a minute because we've got a little bit of time, but I want to take this opportunity to, number one, thank Fujifilm. They've been an incredible partner in this course, and I want to thank them very, very much. And I echo what Anthony said at the beginning. I think for many of us, for many, many years, Fuji was a double balloon company, and you committed just one stack to a Fuji if you wanted to do a double balloon endoscopy. But it's clear, and this began a while ago, that there's been an incredible investment in many, many areas in Fuji. And for me, it began, I don't know how many years ago, but the two things that made me aware that Fuji was really evolving and coming to the forefront was I think I was in Europe and saw the imaging improvement that they had done, and also the studies that they had done on BLI and comparing it to NBI, and it became obvious that Fuji was really committed to improving their technology, and it began with improving their imaging. And then, as you've heard from Pierre, they've just their portfolio has sort of exploded, both in terms of improving endoscopes as well as accessories. So congratulations to Fuji, and again, thanks for partnering with us so well for this course. But you're most excited about EUS?
Yes, because I saw the evolution, and the evolution in the last years. Well, we were waiting for a new scope because I'm Olympus. I was starting with Pentax, of course, and Toshiba, and then we moved to Olympus. And we have been waiting so long for some improvements in the scope. And for example, sometimes we cannot puncture a lesion because the axis of the puncture is not sufficiently perpendicular. And so all these new features, well, I'm sure Olympus is developing same improvements, but that's slightly lagging behind Fuji at this stage. And all the features that Takao Itoi showed you are very important if you want to get access to the bile ducts, if you want to get access to difficult lesions in the head of the pancreas. So I think these were really game-changer improvements.
Yeah. Any comments, Thomas?
Well, glad to hear that you had to go to Europe to discover better imaging.
The epicenter of the world for endoscopy.
Not sure, but anyway, Pierre, we can grill you because Takao has left. EUS, you know, when Rob and I think back, it was all about imaging, right? Imaging and layers and discrimination and stuff. Now the focus is on discovering something dark to put a needle in and something very black to put a stent in. So what role will imaging play? Should we be retrained? Will it be AI and we just press a button and AI tells us? What's your vision?
Well, I think for the pancreas, we need an excellent imaging of the pancreas. Those lesions in the pancreas, especially when you have chronic pancreatitis or if you have variations of the parenchyma, they are very difficult to analyze. And I think AI will help us for sure. But as we heard yesterday from Jacques, AI can only help us if we can give them a broad images, not only B mode, but maybe DFI plus contrast plus elasto, and putting all those images together will help us, I think, to characterize those lesions. So I think we need improvements in imaging, and we have to prove that these innovations are really helping the differential diagnosis. So I think for pancreatic tumors, it's not only puncturing. Of course, that's the final step, but also to be able to puncture at the right position and not to have to repeat those, because we have patients who have to puncture 2 or 3 times before getting the final diagnosis. We know that contrast can help us. So now that we have DFI, which is just a knob, that may be a step forward to improve this. And we are going also for the liver. And I think for the liver, we need a very good imaging. We don't need just, see the liver. We have to be very precise in detecting the vessels and detecting the bile ducts. So it's important.
Thanks for fighting back. Luminal staging, isn't it a shame that we have given up? Neoadjuvant therapy, everything. Is it a lost battle, or what do you think?
Well, we understood that there were limits, and especially we move more and more to the superficial and the more superficial lesions, and we know there that EUS is less sensitive to be able to stage the lesion precisely. And we have the resection techniques that can provide excellent staging and that are not avoiding any surgery or any further treatment. So I think there we lost the battle.
So you don't expect...
Although the imaging is much improving also for the luminal.
So you don't expect improvement from all those sophisticated imaging technologies to better discriminate infiltration?
Maybe not for the lumen, but for example, for bile ducts, when we have to analyze the bile duct, cholangiocarcinoma or sclerosing cholangitis, or maybe screening of those patients with dilated ducts to detect appearance of a lesion. I think there we need very precise imaging to see the differences. And then maybe a detective flow or those new innovations may also help you differentiating inflammatory from malignant lesions.
So Rob, you don't fight for luminal either? No.
No, I understand where you're going, and I think, to be honest with you, I think you're right. I think if all of you look at your portfolio of cases for EUS, it still is primarily imaging. In this conference, we're talking all about intervention and so forth, but the day-to-day practice of EUS is still primarily imaging. And I'm like Pierre. I want to see an evolution of the instrument, and I think many of the things that Fuji has done with the elevator and increasing the angle, the perpendicular punction, I think is really good. But we still need to do work on depth of penetration is a big deal for me. I don't understand why we can't have more effective depth of penetration. So I think there is a lot of work still to do with imaging, and I don't want to give up that imaging.
But that's, Rob, that's because we don't know the platform very well, because in fact you can change the depth and you can adapt. I'm always amazed when I see these endosonographers keeping the same range, the same depth. No, you have to change. When you examine the liver, you have to go to harmonic. You can change a lot of things to improve the imaging, but we don't use all the features that are offered by those platforms.
So it may be that our practice has to catch up with the technology improvement. Yeah.
So next year, come back for imaging teaching,
yes,
right?
Next year, it'll be EUS and come back for the imaging. So, okay, Pierre, thank you so much. Really, really appreciate it.